evening. I am Dr. SAMEER Kumar, working as a consultant interventional cardiologist at HSK Hospital, Bagalkot. Today I will be speaking on the role of antiplatelets and statins in secondary prevention. The focus will be on atorvastatin and clopidogrel. Statins are the mainstay of treatment for any cardiovascular disease. It also includes cerebrovascular accidents and acute or chronic peripheral arterial diseases. There has been a lot of emphasis on high intensity statins in high risk groups, including for secondary prevention, diabetics, dyslipidemia, and the goal would be to reduce the LDL cholesterol by at least 50% or to get it down below 55 mg per deciliter. Statins have been studied extensively for both primary and secondary prevention. It has a number of beneficial effects including plaque stabilization, reduction of platelet aggregation, reduction of platelet activation indirectly, pleiotropic effects, reducing the endothelins, and reducing the adverse cardiovascular events. Compared to placebo, statins significantly impact the quality of life and also reduce the mortality in patients with atherosclerotic cardiovascular diseases. Atorvastatin has been extensively studied. IDEAL and TNT trials are two of the many trials to name which have been studied for patients with stable ischemic heart disease. In this era where diabetes, hypertension, atherosclerotic cardiovascular disease has increased significantly over the past decade, statins form the cornerstone of therapy in all these patients. An addition of antiplatelet agent which has less of bleeding risk and also a lot of beneficial effects is the most ideal one. The routinely available ones are aspirin and clopidogrel. The issue with aspirin being high risk of intracranial bleed and the tendency to cause gastric ulcers in elderly individuals. So clopidogrel and atorvastatin forms a very ideal combination. There are a lot of trials which show that clopidogrel can be preferred over aspirin, especially in cases wherein patient has had a previous cardiovascular cerebrovascular event. The host exam study showed that clopidogrel compared with aspirin is associated with lower risk of MACE. Statins significantly reduce the mortality and morbidity and also reduce the hospital stay if started at the start of hospitalization. So the standard therapy would be to start on clopidogrel and atorvastatin, especially in follow-up patients, that is after finishing 1 year of or 12 months or 18 months of dual antiplatelet therapy. Now according to the newer guidelines, the major emphasis is on single antiplatelet therapy and high intensity statins. So especially in elderly individuals, high risk individuals, clopidogrel and atorvastatin forms a very good combination for both primary and secondary prevention.